చాలా రోజులైంది. చాలా రోజులైంది సార్. ఎలా ఉన్నారు?
అవును. ఇప్పుడు ఐఎంఎస్లో ఉన్నారు కదా?
ఎస్ సార్, ఎస్ సార్.
సార్ డాక్టర్ రామారావు సార్, మీరు ఉన్నప్పుడు ఐఎంహెచ్ ఉందా సార్ 1965లో? సారీ 1970s ఆ టైంలో?
ఎవరు?
అంటే ఇన్స్టిట్యూట్ ఆఫ్ మెంటల్ హెల్త్ యు ఆర్ అవేర్ ఆఫ్ సార్? అప్పుడు మీ
No. No, we were pretty shielded from rest of the world.
Sir.
Just the Kakatiya guys, and we have pretty close relationship with Gandhi and Osmania medical schools.
Sir.
Other than that.
And the professor, Dr. Raghuram Reddy, sir, he is the senior most professor.
Yeah. So our principal was Dr. Dharma Rao. He just passed away a few years ago.
Sir. And VLN Rao garu undena sir meer unnappudu?
Evaru?
Dr. VLN Rao garu, physiology professor.
I don't remember the name though. Physiology professor.
One physiology
professor was one of them was Dr. Tandon.
Sir.
I still remember he was one of the best teachers I ever had in my life.
Sir.
Who, sir?
Dr. Tandon, Tandon.
Tandon, sir. Yes, he passed away recently, sir.
Oh, okay. Oh, he was so good.
And his son is a gastroenterologist in Hyderabad, sir.
Oh, okay.
And he was one of the most welcomed guests, sir, for the Diamond Jubilee celebrations. He came for the program, sir.
Oh, wow. Really, he was the best. No, you would just, I don't have to even read, just listen to his lectures and that's it. That's good he was.
George bhai, it is 8:02. Shall we start by 8:05?
Yeah. I think good. Almost there are 50 members. Yeah. 44.
So the plan is I'll start, and after that I'll hand it over to Dr. Dinesh. Dr. Dinesh will introduce yourself and Dr. Nageshwar Rao sir. And from there you take over, Dr. George sir, and you introduce sir. Dr. Nageshwar Rao sir will do the context setting. Then sir will start. Ramarao sir, and Fanikant will give vote of thanks.
Okay.
Shall I start now?
Yes, I think 50 years. We are done with 50.
Can everybody mute? Good evening, everyone. On behalf of Indian Association of Private Psychiatry and Telangana State and Hyderabad Psychiatric Society, I welcome you all for this wonderful CME on adolescent mental health problems. We have Dr. Ramarao sir from US who would speak about, who is also head of department at a university in USA, and he would talk about problems faced by adolescents and the management part of it. This is generally not taught to us in our colleges, and this area is like gray area. Left child psychiatry is taught and adult psychiatry is taught, but how to deal with adolescents is generally not taught much. So we thought of having this topic, and from that we have sir Dr. Ramarao sir, who is a consultant and specialist in that area. So I welcome you all for this wonderful CME. Now I would like to request Dr. Dinesh to introduce the chairpersons. Dr. Dinesh sir.
Sir, good evening, sir. A warm welcome to all the esteemed members of Hyderabad Psychiatric Society and members of IAPP Telangana branch, and especially Dr. Ramarao Garu, to this very interesting CME today on adolescent mental health in current India. Now I would like to introduce today's chairpersons. Both are very senior psychiatrists and well known to everyone. Professor Dr. Nagareshwara Garu is a senior psychiatrist and he needs no introduction. Sir is currently Professor and HOD Department of Psychiatry at SV Medical College, Tirupati since February 2017, and he is also currently Deputy Superintendent of SVRR Government General Hospital, Tirupati since 2019. Sir actually is a very senior member of Hyderabad Psychiatric Society, and he held various positions in HPS as Honorary Treasurer, Secretary, Vice President, and President. He did his MBBS from Karnool Medical College and MD from SV Medical College, Tirupati. Sir worked as a medical officer in a rural PHC in Karnool district from 1998 to 2001. He worked as assistant professor in Gandhi Medical College from 2007 to 11 and associate in Usmania Medical College from 2011 to 16. Sir was also an EC member in IPS AP chapter from 2015 to 16 and EC member of IMA North branch of Hyderabad, and he was also a very active member of research building committee of IPS South Zone from 2018 to 21. So he took up very many initiatives to incorporate various measures to strengthen the academic and research capabilities of undergraduates and postgraduate students in psychiatry and faculty and members of different professional societies. He worked in various aspects of managing, counseling and treating the public during floods in Kadapa, Karnool, and malaria epidemic in Paderu agency area, and current ongoing COVID pandemic also. Welcome, Nageshwarao sir. Thank you for accepting our invitation, sir.
Thank you, Dinesh.
Dr. George Reddy is a senior psychiatrist in our state. He's a consultant psychiatrist in Healthy Brain Clinic and Hospital. He did his MBBS from Kakatiya Medical College and DPM from Guntur Medical College. He is currently president of IAPP, Indian Association of Private Psychiatry, Telangana State Branch. He is also treasurer of Telangana Private Psychiatry Hospitals and Nursing Homes Association. He is a very active member of our state branch. He was past president of Hyderabad Psychiatric Society. He is also a founder and past honorary general secretary and of IPS Telangana State Branch, and currently is vice president and president-elect of the Telangana State Branch. George Reddy also is honorary consultant to Missionaries of Charity Hospital at Secunderabad and Vijayawada. He also visits SPS Charity De-Addiction Clinic, Don Bosco Navjeevan Home for Street Children, and is also honorary consultant for Sahayam Clinic in Usmania University campus. He also runs rural clinics in Siddipet and Gajwel, which he has been doing very religiously for the past 20 years. His areas of interest are substance abuse and de-addiction, child psychiatry, and rehabilitation psychiatry. Good evening, George. A very warm welcome to you.
Thank you, Dinesh. Thank you.
Now I hand over the proceedings to you, George. Thank you.
Thank you, Dr. Dinesh. At the outset, first, I think I will thank my friend Dr. Minhas for taking an active initiative to introduce a renowned speaker, Dr. Ramarao sir, to all of us. Today's topic, I'm sure, I think it's one topic which we are eager to hear from the esteemed speaker. I think at least very less is talked about this area, might be the adolescent group, and might be the child psychiatry is picking up in our country and in our state too. I see many youngsters showing interest on child psychiatry, and might be the adolescent psychiatry also needs a focus. And without taking much time, I would like to introduce today's speaker, Dr. Ramarao Gogineni sir. He is an alumni of Kakatiya Medical College, 1965. He did his internship house surgeon at Usmania General Hospital, and later he moved to Pennsylvania University. He did his MD psychiatry there, and he did his child and adolescent fellowship there at University of Pennsylvania, and he is trained in family therapy and psychoanalysis, and is currently the professor and head of the department, Child and Adolescent Psychiatry Wing, and is currently the professor at Cooper Medical School at Rowan University, USA. I think he needs no introduction to many of the WPA members. He is an active member of the World Psychiatric Association, and he has many publications and books to his credentials. And I think we'll be hearing from Sir even at the Vizag, our national annual conference of the Indian Psychiatric Society, ANSEPS. With this small introduction, I request Dr. Nageshwar sir to introduce the topic.
Thank you, Judge. I thank the organizers, especially Dr. Minaj, for inviting me to be the chair of the session. And it's a pleasure to host be the chairperson when a eminent speaker from US, Dr. Ramarao, has been talking about the topic, especially on adolescence, which is most neglected, and at the same time, adolescent being more vulnerable age group wherein substance abuse or it could be behavioral problems are. So it is difficult to understand an adolescent. So being from dependent to independent, a transition wherein that is happening, and there is so maturity that is happening in the brain. So I think this topic, selecting this topic, I congratulate the organizers for having this topic, and I hope Dr. Ramarao is the right person to talk about this. I request Dr. Ramarao to go ahead with this presentation. Please unmute, sir.
Share.
Yeah, please go ahead, sir.
Okay, all right. First, I want to say when you guys say seniors, I'm 72 years old. I'm super senior, guys. But luckily, I'm still in good health. I'm fortunate. I feel blessed that I am able to talk to you guys, young people like you, and being invited by my own alumni. You know, we talk about in I don't know how many of you are familiar with Maslow and Bandura's work. It's called self-actualization. That is when you reach certain age, maybe 50 plus or minus, we have this need to give to youthful other people. It's important for us to have the opportunity to give what we are capable of giving to others. It's not a really being goodness. It's a need for older people. Thank you for all of you for satisfying my self-actualization needs. It's wonderful. So I want to thank first actually maybe I'll start off with my great gurus from India recently though. In addition to Dr. Dharmarao, my principal, who was so kind to me. So the Dr. Sridhar Sharma, Roy Kaliwayalil, Rakesh Chadda, and boss Dr. Basu. They are my kind of connection to Indian scene. They promoted me, they take care of me, they're very kind to me. So the four of them really are wonderful to me. And of course, recently my IAPA organization in America and the Indian Psychiatric Society officers, and of course, you guys from Hyderabad and Telangana. I don't want to mention all the names that I need to thank for the sake of the time. I can't thank enough, particularly Dr. Nasir Abadi. He is just a gentleman and a scholar and a kind person. Thank you very much. So I'll move on to the presentation. One interesting thing about adolescence, though, if you follow the history, can you guys hear me okay?
Yes, sir. Loud and clear, sir.
Okay, all right. What come I have to, why can't I move this? Okay, all right. I don't have any disclosures. I'll just say a little bit about, this is the outline. I'm not going to spend too much time here. The only thing I want to say about the Indian scene, I didn't realize how much I don't know about the Indian scene after I started preparing it. Because I'm so far removed, even though I come to meetings, attend meetings, listen to all the people, but still because I'm not directly there. So I might not do justice to presenting the Indian scene, even though I read quite a bit to prepare for this one. But that's all from reading, not from a first-hand experience. But I do work with a lot of Indians in America, though, so I don't know how much that helps. One thing I want to say about adolescence, though, one, we think even though you think you don't know, you'll be surprised how much you know about adolescence. One of the things I teach my residents and students and myself, we are trained to think we don't know, even though we know a lot. About cognitive therapy, psychodynamics, adolescence, childhood. We are trained, as students, we're trained to think developmentally we don't know, even though we know a lot more than what we think we don't know. So part of my job really today is to help you to understand how much you know, but it's hidden there somehow under the what I call systemic aspects of the ignorance, systemic racism, systemic classism, systemic studentship. Students are trained to think we don't know so that we can learn more. That's different. That doesn't mean we don't know. So we are trained to think we don't know. The second aspect of adolescence is, if you look at the history, literature, adolescence is the most celebrated age. All heroes are teenagers of the world. Whether Gandhi or Buddha or Jesus, Muhammad, all of them were teenagers when they became famous. But also the most villainized are also adolescents. We see them, we think they are no good, spoiled brats of the world. So we have this dual relationship with adolescents. On one side, elevating them to this romantic, intellectual, scholarly level. The other side, demeaning them as children. So depending upon what we think, how we resolve our own feelings about being a teenager, and how we perceive them in today's world, we elevate them, romanticize them, and then also demean them and put them down and get angry at them. It's important for us to keep this in mind when we treat them, when we relate to them, when we discipline them, or when we elevate them. There is something about the world, human evolutionary aspects. Remember, adolescence is the most reproductive age. From a Darwinian perspective, they are the one who propagate species. Number one Darwinian principle is propagation of species, and second is survival of species, right? If you look at the Darwinian concepts, both the reproductive and the warriors are also teenagers. If you look at them, they're the protectors and the reproductors of society. It's it's important to keep that in mind. So when we are ready to defend our tribe, we become teenagers. No, we fear nobody. We use our brilliance and our creativity, our geniusness to take care of our tribe and race and caste and class. So keep that in mind. Though. That's why I think you guys know a lot more than what you think you do. Keep that in mind. I tell the same thing to the parents. That is, they know a lot more than what they think they do. So by saying it, you're elevating the status of the parent. Yeah, you are a good parent, smart man, smart woman. You think you don't know, but you do know a lot more than what you think you do. It's what I call positive psychiatry, but it's more than positive psychiatry. That's a fact. That is, our anxiety, our own inhibitions makes us think we don't know. And our own need to contain our own aggression makes us think they're aggressive. They're not. I'm not saying they're not. There's something about projection of our own needs, psychological aspects to the teenagers contributes to our thinking we don't know. The other interesting thing, it's fascinating how medicine makes adolescents as children. If you look at their reproductive age, 12 or 13, they're practically adults. Somehow the legality of the society makes them children. So physiologically, they're very much adults. But the legal limitations that the medical world and society makes us think they're children. They're not children. They're not just adults, but they're not children. Most of the guidelines that are implemented, even by ACAP and American societies, I don't take them very serious. Not, of course, legally we have to though, because for all practical purposes, they're adults. Reproductively, physiologically, yeah, brain will continue to grow for a while. That's why I'm going to come to that one for a little bit. The rest of the body is pretty much adult body. So we know about this is exactly the 10 to 14 years, the phase of vulnerability. Also phase of creativity, phase of reproductivity, phase of intellectual contributions. There's some fields, experience helps, but the creative fields starts during 10 to 14, creativity of human beings. It's important to keep that in mind. Experience helps in some fields, in any field, to master, but not the creative. There is a difference between creativity and intelligence, right? We know about that. The creativity starts as a teenagers. This is, I like this slide. It's more a medical slide, which talks about the nutritional disorders. By the way, it's growing in America, in India also. We'll come to that a little bit when we talk about eating disorders. Drug and alcohol use, Dr. Nageshwar Rao already said this about this. That is, it's a major issue. By the way, when I was a medical student, I heard about people using Quaaludes. That was the most common abused drugs in medical school at that point. And we would go to the pharmacy and get medications to stay awake. Guess what they are? Stimulants. I never heard of stimulants as a medical students, but we would take them to study. Now they're drugs of abuse. And we know about the high-risk sexual behaviors, a lot more in adolescence. And of course, most of the mental disorders start during adolescence earlier. Doesn't matter what it is. Psychosis, OCD, depression, anxiety, bipolar disorder. Most of them you can see either illness starting early on or precursors of the illness start earlier. For example, or one example I can tell you is, I don't think we will talk about it, Dr. Blocking the name of the doctor, one of the researchers at Penn. She's studying the children of schizophrenics, their MRIs. What she's discovering, Dr. Gur, Dr. G-U-R, Gur, she's studying the psychological testing and the MRIs of the children of schizophrenics. What she's finding out is starting age 12, 13, they start showing blunting of the facial expressions and some sort of learning problems. And it continues to grow as they get older and they become full-blown schizophrenics around 20, 25, or sometimes 18. So what that means is they're starting to show symptoms of schizophrenia early on. So the question is, if we sense what happens because of it, because they get teased, they become lazy, they have some sort of high vulnerability of psychosocial stressors. So they become couch potatoes and their self-esteem gets affected. So by the time they reach about 20 years of age, they have a lot of negative symptoms of schizophrenia. You know about the PANS, right? Positive and negative symptoms scale of schizophrenia. So they have lots of negative symptoms, which really makes it hard to treat them. Now the positive symptoms, the antipsychotics work pretty well. The negative symptoms of which have origins most often during teenage years. So that means they're so internalized into the personality structure and the brain structures at a different level, not just the dopamine. So if you can think about it, you can tell the parents, you can tell the patients, and you have to do a lot of rehab. India is famous for rehabilitation, better than America. You have so many rehabilitation services. So you can prescribe rehabilitation services to treat the negative symptoms of schizophrenia, because the negative symptoms of schizophrenia origin is during teenage years. That's an example. Mental disorders. Then, of course, injuries and suicide and violence would come to that later. I want to say a little bit about the growing adolescents. Again, this is important. I already said a little bit about this. That is, the teenage years are the beginning of becoming a man or a woman, both in every aspect, physically, emotionally, intellectually, cognitively, sexually, you name it. Also beginning of these mental illness, physical illnesses, particularly chronic illnesses, as well as all the bad habits, drug addiction, violence. If you look at the history of violence in US, most of the violence begins before age 30. Very few people start their violence after age 30. If it starts before 30, then it can continue to become violent. But the beginning of the violence are most often during teenage years or post young adulthood, before 25. You guys know about these things, puberty, first change is the enlargement of the testicles. By the way, it's important to ask these questions if you feel okay about this. That is, when did you become pubescent? And if they don't know what that means, is please ask them, when was the penis got bigger and the testicles got enlarged? So if you medicalize those questions, it's easy for people to open up. Don't do it, don't be ashamed, don't feel ashamed. Don't think you're asking personal questions. You're asking medical questions to understand the onset of puberty onset of changes in manhood and womanhood, and illness, you name it, everything. So if ask them as soon as possible, first or second time you see them. And also they feel less shame if it comes from you. The shame about feeling all these things holds them back from opening to you. So when I ask these questions, when was the first time, they kind of giggle. Then you explain the reason why. Once you explain the reasons why you want to know, most of them open up to you, whether they're Indians or Muslims or Hindus, doesn't matter. Because they see you as a doctor that wants to help them with the problems of becoming a man and a woman growing up. It's not just shame-ridden private question. It is a medically based information gathering, medical information. Of course, pubic hair, wet dreams. I don't ask wet dreams, but it's not a bad idea to ask about wet dreams. They might giggle, but they might tell you. Particularly now in this day and age of sexual orientation, gender issues, one of the things I ask often, the most often, to understand gender and sexual orientation, their masturbation fantasies, their dreams, not about exactly what they practice. If they have fantasies about a woman or a man or both, or what they picture themselves in the fantasies as a man or a woman, that gives you a kind of window into understanding their gender issues and sexual orientation issues. And when you should ask, it's okay, I don't know when, but just make sure it's a medical question. It's not a private, secret question. If you feel okay, I can tell you most of the kids will open up to you. About the girls' puberty, I think breast development, pubic hair. This is important, the social changes. You can ask them again, when you should ask, if you're treating a teenager, definitely you should ask. I'm going to say a little bit more about each of them. You guys know about the abstract thinking. If you don't know, let me explain a little bit about abstract thinking. The Piaget, Jean Piaget, has stages of cognitive development. The last stage is the abstract thinking. Before that, concrete operational thinking. Before that, the two steps before that were pre-operational thinking. Abstract thinking is the question why pops up. So what happens when the teenager starts thinking why? They have a lot of anxieties. They feel shame. They feel guilt. They have superiority complex. They have inferiority complex. They have self-esteem issues. All of them pop up. And also, they become wise guys. They question everything you do. Why? Tell me more. You're stupid, daddy. You're stupid, my uncle. Because they start thinking abstractly. By the way, one of the things I want to say a little bit just about Erickson has written this famous book about Gandhi, the autobiography of the Mahatma Gandhi. He says Gandhi's abstract thinking, when he was a teenager, laid foundation for Gandhi to become who he became. Beautiful. That's true about most of the great men and women. As a teenager, when they start, their brain grows to the maximum size. And they're cognitively, they start thinking why, they become scientific. Of course, they think about philosophy, politics, social issues, think long-term, set goals, compare himself to others. Again, same thing, because of the abstract thinking. This is this bullet is important. second individuation. So I'm going to say a little bit about this. That is, they start moving away from the family. The first individuation, by the way, is the when about age 3 or 4, somewhere up there, when the child moves away from mom. He becomes a big boy or big girl from away from the mom. He doesn't need mom every minute, or she doesn't need it. But when they become a teenager, they don't need the family. They move away from the family and become themselves. That's the time they may feel anxiety, and the parents start thinking, oh, he's moving away from me. He's a big shit now. The big shot, whatever it's called, depending upon what they think. Is it a big shot or big shit? If they're angry, they don't like it, they call him big shit in America. And if they think he's grandiose, think he's too much about himself. But that's not. He's trying to, or she's trying to establish an identity of her own away from the family. By the way, the third individuation, when it's not here, is when we reach about 50, what we call middle-age crisis. We are moving away from the tribe. We become more worldly. So that's when we become politicians and leaders, or the Nagesharovs of the world. You're all at the third individuation phase. You're thinking about the larger world, not just about your family, not just about your caste, not just about your region, not just about your class. You become more worldly. That's what the third individuation. That's the Erickson's stages, though. A little bit. Actually, second individuation appear a blow stiff phases, but they're all kind of developmental psychologists, psychiatrists. And of course, peer influence, romantic, sexual relationships are important. They're all part of the puberty, sexuality, hormones, and individuation issues. And they become romantic, and they start thinking about love and long-term commitments and relationships. I'm going to say a little bit more about the next slides. My wife thought maybe I should not have other slides, but I didn't take them out. I thought it's a nice, cute picture describing a lot of the changes of the maturity. And this is all the bad stuff about, crazy stuff about the teenager. I like these two pictures. I'm going to say a little bit about this. The adolescent brain. By the way, I have a little longer version of these things in my practice. When I see teenagers, I make a copy of this slide and give it to parents and the child. I'll send you the bigger version of my PowerPoint. I just make a copy of the page-long copy of this brain development and give a copy to the parents and the teenager. This is what's happening, man. This is the story. It's not you, it's your brain. It's not the reason a lot of the things you're doing, you're not doing because your brain reached its peak in many ways. Greatest growth spurt, gray matter. By the way, the other thing that happens here, it's not in this slide, they lose some old skills, like a tadpole effect. Until then, my own son was great with puzzles. He would just do like that. But after he became a teenager, he stopped doing it. After understanding about the teenage brain, they have a tadpole effect of the brain. Most of us lose some skills, something that we had when you become a teenager. We think they become lazy, not necessarily. The other thing that happens because of the growth, the differential effects of the intelligence starts affecting you a lot more. Somebody could be great in math, but not great in reading. So what do we think about them is they're lazy in reading. They may be, but they're, oh, you're so good, you're so smart. Why don't you do what you're supposed to do? Sometimes it is laziness, but sometimes it's not. It's the differential effects of the intelligence growth. My part of the brain grows a lot, But the reading part does not have a capacity to read more than average. I treated this kid who I still see him though. He's in his early 30s. He has a math IQ of 145 and reading IQ of 110. He's still above average, but there is a 35-point difference between his math IQ and reading IQ. So all the teachers and the parents thought he was lazy. That's why he was not doing well. Not so. Because when he talks, his verbal IQ is 145, his math IQ is 145, his reading IQ is only 110. So everybody thought he was lazy. So they were getting after him, making him feel bad, and he was feeling bad. So when we tested him, what we discovered is this 35-point differential IQ. So when I discussed this with the kid and the family and the teachers, what you get? Aha response. Oh God, that's what it is? I didn't know that. Now it makes sense. That made him feel better. Family accepted him a lot more. And we designed some interventions so that he can be average in reading and make use of his powerful math brain and verbal brain. He's very good in talking. The adaptive potential, overproductive selective elimination. I think I'm going to skip that. This is important. These changes and enormous plasticity of teen brain makes adolescence a time of great risk and great opportunity. Jay Geed, by the way, for people who have access to NIMH website, please look for Jay Geed and read his research. He has a lot of YouTubes. He's one of the greatest scientists that I love him though. He's a fantastic teacher. There are a lot of YouTubes that he made for NIMH. I also ask all my parents, kids to look at his YouTubes. It helps their understanding of what's happening with the teenage brain and mind beautifully. There are a whole bunch of other things. I happen to like Jay Geed, but there are quite a few other scientists. Again, he's a big name at the NIMH, and he's also a nice guy. He's very humble. And a little bit more about the adolescent brain. You see the functional, structural. As I said, I put all these things on one slide, one copy, and then give it to parents and teenagers. The functional structural increases connectivity and integrative process as distributed brain modules become more and more integrated. Second change is the generational pattern of childhood peaks of gray matter, frontal, temporal, occipital lobes, followed by adolescent declines. As I said, they lose some things. As parts of the brain are overdeveloped and then discarded, the structures of the brain become more refined. The third change is the balance between limbic and subcortical and frontal lobe functions that extends into the young adulthood that increases executive functioning. Prefrontal cortex is largely immature in teens, matures by, I'm going to say a little bit about this. This is important, the fourth bullet. The prefrontal cortex does not mature until they are 25. That means they're hyper, they're inattentive, they're distractible, they act stupid, even though they are not. It's not because they're stupid, because they haven't developed the executive functioning. It's important. What that means is they have to spend more time. We need to help them to use their brain properly. It's there, but the executive functioning is lacking. The intelligence is there, learning capacity is there, creativity is there, but not the executive functioning. That's why they get into accidents before 25. That's why the insurance rates are high before 25 in America, because they get into accidents. They act stupid even though they have big brains. They make mistakes. They're risk-taking. Not because they're just risk-taking. They're not using their brain properly. So if you can just highlight this aspect to parents and the young adults, it's not you, it's your prefrontal cortex that's making you act stupid. An increase, about the only thing I want to say about the hormones is a lot of the people think it's all hormones. No, it's not. Hormones is part of it. A lot of it is the brain. By the way, I want to say one more thing about the India and the brain. I don't know Muslim habits, functions, but if you're a Hindu, Hindus celebrate the 6 months, 1 year, about 4 years, and about 11 years as celebrations, big functions. That is the time when the brain has what we call continuous growth and surgent growth. It grows slowly, steadily, and they go overnight. It gets bigger, kind of. That's called surgent growth. Boom. Slow, steady, and booms. Each boom, you enter a new phase. What happens at 6 months? Instead of eating liquids, the child starts eating solids. So what does the Hindus do? They celebrate solid food. The first, rice and butter, or ghee. First time you have function, you invite relatives, friends, when you feed the rice and the ghee. What do you do when you're 11 or 12? You celebrate, you give them panchalu and seeralu, right? Vani function. So you're celebrating their brain growth, not just the hormones. They're starting to think abstractly. They become young men and women. That's part of the culture, customs. I think most of the religions have similar kind of baptism in Christianity. Is there anything like that? There must be something like that in Islam also. I just don't know. That, of course, Indian Muslims, they do have a circumcision around that time, right? I think. So there is a function. This is just a little bit more about the previous one. The brain reaches its biggest size in early adolescence. The brain continues to mature even after done growing. That's important. The teen brain is ready to learn and adopt. Many mental disorders may begin to appear during adolescence. Teen brains may be more vulnerable to stress. Teens need to sleep more than children and adults. I don't know that though. It's an interesting problem. They do sleep a lot more than probably they do. Maybe we think they're lazy or they're being teenagers. But it's interesting though, that do need more sleep than children and adults. Keep that in mind. The teen brain is resilient, absolutely. Keep that in mind. So don't when they're acting bad, this is one thing I tell them. Give them hope, parents. You and I, and the teachers, and your uncles, and your aunts, and your friends, we all work together to help you to overcome what you are going through. I have 100% faith in you and your family because you're a good kid and you have a loving family, you have wonderful friends, and you have a good support systems. We're going to beat the crap out of your problems. By the way, I do like to talk like this with my kids though. We will beat the crap out of your problem. We are all on the same page. So it's what I call lending them your ego. That's what I call it. You give them your strength. And we are going to work together. You, me, social worker, therapists, teachers, your uncles and aunts, your family, we all will work together and make you who you can be. Don't tell them, make them president of India. make them who they can be. That's the key word. We all have our limitations. No. uh, uh, this is I like this a lot. This is a paper I recommend all of you to read this beautiful written paper. I think it's in the Asian Journal of Psychiatry, 2015, written by Agarwal and Burke. How much time we have? We'll stop at 30. In a 15 minutes. Anybody tell me how much time we have?
So you have another half an hour, sir.
On half an hour. Okay, all right. I'll just rest with the rest of the slides. I'll half an hour. I'll just say 15 minutes, and I'll finish my talk, and then we'll have questions. All right. Mental health of adolescents in current India. I'll say a little bit about this though. The psychiatric morbidity. This is interesting. By the way, the first bullet is beautifully done. That is, you already know this one though. I'll just read out loud. The last 10 years, there have been dramatic changes in socioeconomic, rapid urbanization, familial structures, literacy levels, economic growth, materialistic social milieu, a highly competitive environment, reduced contact with and support from extended families, reduced parental involvement in children's life, modern lifestyle, and reduced involvement. What I say is this, instead of saying all these things, there is a human Darwinian evolution, slow study, and there is cultural evolution. The cultural evolution is so fast, our brains and our bodies are not catching up to the cultural evolution. There's a big gap because of all these things. That's why a lot of problems. Not only changes, the brain is not evolving, the human brain, because of the brain evolves slowly than the culture. So we need to do all kinds of things to catch up, to train our brain to catch up to the cultural needs. For example, studies, right? When 50 years ago, you would read about one book. Now you have about 200 books. You have to read 20 subjects, not small one subject. So the demands on the brain are multiplied when compared to the brain growth, evolution of brain growth. It's important to keep that in mind. The second, this one is the psychiatric morbidity ranges from 1.8 to, these are interesting numbers, right? Depression, 0.5 to 60%. Only thing I can think of why this is so, in addition to urban differences, villages, gender, economic classes, there may be something more to it though. That is, so for example, I'll tell some examples here. I see it. I think it's probably true. People who grew up poor for generations, they don't have high dreams. Not having dreams, not thinking about mental illness, not thinking about depression, not thinking about learning problems, makes them accept their limitations more than they should. They don't even complain. They don't even look at these things. It's a very common problem here. The culture, what we call systemic culture, doesn't prepare them to think about all these things. And the other side is true. People who are upwardly mobile, we think too much. We become too neurotic. Oh, maybe there's something wrong with me. Maybe there's something wrong with my son. So we kind of exaggerate the problems. The culture divide, systemic aspects of our class, occupation, caste, class, and all those things contributed to, I think, to these numbers differences. Um, this is just another slide. I want to say a little bit about this. Yeah, I think you already know this. An increased interest, internet use makes it difficult for parents to control this access. This is COVID-19. Yeah. I'll skip this one though. You probably read a lot about these things. I want to say a little bit about this though. This is important. I was reading about Dr. Priya Shankar's blog on internet. She grew up, I don't know where she grew up. She grew up somewhere in India and was depressed and suicidal. She's a pediatrician now at San Francisco. She started a blog and support group for understanding teenage girls. And this is what she wrote. That is, suicide rate is pretty high. Girls are at a high risk. Mental illness, depression are pretty high in girls. There is a lot of stigma. Different kinds of stigma, including her crying. There's cultural resistances, multi-generational consequences of mental illness. This is interesting though. What I also see is a form of systemic aspect. If there's depression in multi-generationally, because grandmom don't think she was depressed, mom don't think she was depressed, the girl is depressed. If you look back, what you realize though, grandmom and mom also were depressed, but they were not diagnosed. They did not get any treatment. So we think there is no depression in the family. We have to be very careful about this. That the previous generations, because they were not diagnosed, because their depression did not affect them as much as it should, because of the demands on their life, they did not see depression. But the granddaughter, who is faced with a lot of challenges, a lot of desires, a lot of needing to advance, her depression is affecting her. It became more prevalent and visible. But it's multi-generational transmission of depression. The previous two generations, it was not diagnosed. It's easy to miss it if you don't think along these lines. You guys know about this suicide is third leading cause of death in teens. By the way, Indians, you guys know about this, both adults and teenagers. We are somewhere in the second or third in the world, right? In teenagers, South Korea is #1, India is #2 in the world. Suicide, Russia is #1, India is #2. I'm sorry, in suicide incidents. So we are right up there, guys. We're high in numbers. So I think about, by the way, I kind of look at the second bullet to diagnose a little bit more. Death wish starts off with death wish, then suicidal ideation, suicidal attempt or self-injurious behaviors, parasuicidality, and then actually it should be suicide though. Most common method is completed by suicide is by firearms. This may be in America though. I don't know what's the most common method in India. It may be hanging, I don't know. I would think it's hanging though. And overdose. Overdose is common in girls, right? Actually, that's true. Predisposing factors, precipitating factors, risk management. I want to say a little bit about this then. Avoidant restrictive food intake disorders. By the way, it's very common though, particularly before marriage. Somehow after marriage, it goes down a lot more. I don't know now though, at least it was the case. Anorexia nervosa, bulimia, and also children of rich people in India. Obesity is as much as in West, about 70%. It's not good. The rich people children have two things in common with the West. obesity, and laziness. We have to skip, don't blame them though. It is a class-based illness, culture-based illness. We need to understand that instead of saying you're fat, you're lazy, that shames them. We need to empathize and medicalize, diagnose them multi-modal way. It is class, it is anxiety, it is reward deficiency, it is bad habits. So we need to help them to diagnose properly. It is an eating disorder, either binge eating disorder or obesity, and we need to help them, or anorexia or bulimia, help them. This is a assessment, level of treatment. These are, you guys know, this is similar to adults. Prevention is the key. Traditional forms of treatment, outpatient therapy, intense outpatient. I don't know how many of them you have though. I'm going to skip most of these things. This is important, the principles of psychotherapy, psychopharmacology for teenagers. Not for teenagers, but keep that in mind, the size, weight, chronological variations, metabolism, growing body, brain, effects on normal development, custodial legal issues, physical, neurological, psychometric examinations, start low, go slow approach with medications, avoid polypharmacy. Medication should be part of the treatment. It should not be for control of behavior. This is an American guidelines though. I think most of them apply to India though. Consider tapering DCing at the earliest possible time. I want to say a little bit about this though. Dr. Karen Janine Wagner. She was the president of the ACAP years ago, a big name in depression treatment from Galveston, Texas. What she says for teenagers, about 9 months to 1 year. First one episode. They didn't need to take it medications for life. If it's the first episode, you should try to taper them off in about 9 months to 1 year. And if it is a chronic recurrent depression, of course, you give it for 2-3 years. You should still try to taper them off. The other interesting thing about teenage illnesses, both including bipolar disorder, we are not sure whether it is similar to adult illness or it's different. Many kids grow out of even bipolar disorder when they're older. So the general consensus is some of the bipolar disorders are similar, but a third of them similar to adult onset disorders, but 2/3 of them, they may grow out of it. That's true about a lot of the disorders. Keep that in mind. I want to say just two words about this. As I was telling you earlier, you think you don't know anything about psychotherapy. I'll tell you what you already know. We know thinking affects our behaviors, right? Negative thinking, positive thinking. And we have negative cognitive schema because of what happened, what we go through. They affect our taking care of ourselves as well as taking care of medications. Think about it. You think you don't know, but I can tell you, all of you are cognitive behavioral therapists, if you think about it. Same thing about psychodynamic psychotherapy. You may not know all the principles, but do you know about the unconscious? Atma, right? That's part of Indian heritage. We all believe there is something more than what we know. Dharma, Atma, all the Hindu principles are unconscious. That is, by the way, actually, the dialogue between Bose and Freud talks about this. Hinduism is deeply embedded in psychodynamic principles. And behavior therapy, we know about that. Learning theory, right? Once you get used to it, that's learning theory. We know about that. Family therapy, family interventions. Actually, the right word is family psychiatry. We use it now. We don't call it family therapy anymore. That is parents, empowering parents. Parents contributed to enhancement. Only thing is, I don't pathologize parents. No, I rarely pathologize them. My job is to make them strong, make them feel good, enhance their self-esteem, parental self-esteem. Tell them they can be better than what they are. They're good, they love their child. Highlight the positives. If you highlight them, if you bless them with your doctoral blessing power, yeah, I know you're good. You can be, I know everything about you. You can be bad, you can do A, B, C, D, E. Empower them. Don't criticize them too much. Don't shame them. Shame has no place in treatment. A little bit, maybe once in a while. And we all do supportive therapy. And India is famous in providing CAM, complementary alternative therapies, mindfulness-based, my exercise. You should be here. Exercise, walking is a great thing. Families walk together. Families dining together. There is quite a bit of research. If the family that eats together at least one meal a day or 2 meals a week and celebrate one family together in a year, the children have less addictions in those families. The key is don't talk about problems when they're eating. Don't enjoy the meal. Oh, this is school, boy. That's enough. Causes problems. Discourage them from talking about problem behaviors at meal. Let them enjoy the meal. Let them talk about something. You can bash Trump or Biden. That's okay. Together. But don't talk about problematic, controversial issues during meal. Because what happens is when you eat, it enhances dopamine. When you think positive, it enhances dopamine. You feel good. Your social brain enhances. Your executive brain enhances. Your traumatic brain lowers. So help the families to enjoy meals together, doing some things together. Enjoy the holidays together without making them controversial. And the reward deficiency, I'm not going, the only thing is I'm big on it, Dr. Claude. By the way, it's interesting. Most of the researchers in India, in America about RDS are Indians. I don't know why that is. It's big name. That is what they say is there are two human behaviors. We all feel unhappy. We need to be rewarded. There is an excessive need for reward and feeling reward deficient. Those two contribute to a lot of the problems. Eating disorders, drug addiction, ADHD, borderline personality disorder, you name it. And that's it. I'm going to skip most of them though. I want to say one word, learning disorders, please keep that in mind. That's a big issue. Same thing, a lot of the children have this problem. They don't listen to you, they get anger problems, they don't follow rules, they steal. So how much, just keep that in mind. I do believe a lot of the children in India have not PTSD, stress and trauma-related disorders. They have a lot of bullying, teasing, class-based stuff, caste system, gender stuff. Sometimes what they call microaggressions in teenage children are so common in India. They traumatizes or at least causes stress-based reactions. That's it. I'm going to skip the rest of it. Okay. Thank you. We will, whatever time we can ask questions.
Thank you, sir.
So you're welcome to have the slides. Use them freely. I'm sorry, sir.
Thank you, sir, for your wonderful presentation and completing in time. And as already told, this is a very special population, being more potential, at the same time more vulnerable. And we have dealt this topic in
Sir, can you stop sharing your screen, sir?
Yeah?
Can you stop sharing your screen,
Oh,
sir?
yeah, that's all I'll do.
Yeah. So I think now it's open for discussion. We have some questions, and mostly most of the questions from Dr. Keshwara, sir. And the first question is like your reference to adolescent as an adult. Presently, UK has replaced adolescent term with young person. Young person needs to be treated with the same respect and attention as adult kids.
I like it.
Mostly it's a comment. Can you comment on it, sir?
See, I agree with the overall concept, though, but we also have a responsibility to adolescents, though. So it's both. We have to respect them as adults, but act responsible as parents and caregivers. We have dual role. Don't forget our responsibility. We have to be role models, and we have to help them to grow up, help them to make use of the resources of the world, be mentors, gurus, teachers, parents. But enjoy it.
Good evening, sir. Keshwara, sir. You want to ask any question again? You can unmute yourself. Unmute yourself. Please unmute, sir. Keshwara, sir.
Yeah, thank you. Thank you for adding with the panelists. Sir, it is a very interesting and stimulating talk. With your experience, of course, you have all the slides, but of course the time is only 1 hour. But you touched on some areas which are very stimulating. And one thing I was very interested was about you analyzing the IQ test and helping the child. This kind of, do you coordinate with educational psychologists quite a lot in USA? Because we don't have any educational psychologists in India. And what we look at the figure, the IQ 70 or 80 or whatever it is, but not going into the sub-tests and where this child has failed. He has a very good IQ in mathematics and but not in reading, and that was helped. So it's very, so I don't know how we develop this kind of systems in India.
Yeah, I don't know, but by the way, another very common problem is what we call non-verbal learning disability. We can't, it's very hard to diagnose without testing. Yeah, testing would help though, but I don't know. Maybe.
There is a lot of scope for educational psychology in India. That's what I feel.
Yeah, I agree with you.
It needs to be properly developed with the psychology, because we have such a small number of psychologists. I think we psychiatrists should also get into, because the number of psychiatrists number is some 30-40 times the number of clinical psychologists. Maybe we should take up more of this kind of work. This I am telling mostly for the young psychiatrists who are coming up in big numbers every year in our state now.
Yeah. Thank you, sir. Sir, Dr. Ramarao, sir, there's a question, sir. The question is from Jyotirmayi.
Okay.
How do we handle bullying, especially with skin color and skin color, etc., in school for teenagers, sir?
Well, I think there are two levels, though. One is how do we handle socially. that's not our job. We can help the people. But the second is, how do we help the victim? That's where we come in, right? We have our job individually with the victim as well as the offender, right? How do you help the bully not to bully? And how do you help the victim not to let the victimization affect him negatively? How do you help the whole concept of bullying, microaggressions, caste system? I don't know. They're all big issues. I think they're important. Schools should have policies. Society should have policies. I think India is doing not bad, though. There is a lot more to be done. But how do you help the victim and the bully? Victim is make sure that he's being bullied for two reasons. One is the bully needs victims. It's not really his problem. Not to take it personally. That is, he's not bullied not because he is dark, not because he is learning disabled, not because he has a cleft palate, but because the bully is a bully. So you should not take it. It's not because of who he is. That's not the reason why he was bullied. So he's as good as anybody else. So he has to not let his victimization affect him. And the second is, if there are some vulnerabilities, for example, children with ASD, autistic spectrum disorder, children with the cleft palate, children with even diabetes, children with serious learning problems become victimized. If that is the case, we need to help them both not only realize that it's not there that they're victimizing, their condition is making them victimized, that separate out who he is and what he has. It helps them kind of understand that he's not the bad person, weak person. There is something about him. The second is help him to teach coping skills. And the third is, of course, if you can recruit supports from the family, school, peer group, that will help.
Thank you, sir. So there's one question from Dr. Paresh Shah. And his question is, sir, how to treat adolescents with school refusal and introverted behavior in post-COVID time? And there's another question from him, sir. Mobile phone addiction is a burning problem in this age group. Your comment, please. How to reduce it?
The first one, I guess most important part is you have to diagnose it, right? What the reason for school refusal. Years ago, when I was in training, I was told school refusal was because the mother of the child was depressed, which may be true still, though. He wanted to, mom needed somebody home so that she will not be depressed. So if you treat the mother's depression, the school refusal will go away. The second intervention they used to do was force the child to go to school, including calling the police. Still, they do it though. Sometimes that's okay. But the reasons are social anxiety is a major reason. Bullying, being bullied, is one of the common reasons. Depression and shyness. Shyness is different than social anxiety. That is, some people are, it's not that they're shy, they just don't want to be with people. Then if you can medicalize all these things, you have it's your social anxiety, it is your shyness. It's again, you train the parents. It's not your child is bad or refusing, he's not oppositional. He has anxiety and he has shyness. So we need to help him with what's underneath. Sometimes you do have to use more some sort of force. That is, then once it becomes an issue, it becomes a habit. We have to help them to change the habit. The way you do it is what we do. It's no longer an issue. It became a habit. You and your parents have to learn how to unlearn this behavior. How to do it? Go to the school. Go to the school for 2 hours. Somebody will be with you for 2 hours. Some sort of using learning techniques, behavior modification. Sometimes you may have to use medication like Inderol for anxiety, propranolol, or a small dose of clonazepam, or an SSRI. Or if they're really thinking too much, perseverating, you may want to use a low dose aripiprazole or quetiapine. Sometimes medicines, small dose, temporarily are very useful to help them not to think too much. They brainwash themselves almost like, I can't do it, I can't do it, I can't do it, I can't do it. Then they can't do it if they brainwash themselves. Then I tell them, it's not just a problem anymore. You brainwashed yourself. Those are some of the things I do. Learning theory, family interventions, medications. Mainly medicalize it though. That's why I'm a big on medicalizing it. Give them a medical explanation. That takes away the taboo and stigma. And give them hope.
Sir.
Thank you, sir.
And the second, internet, I don't know. It's a real issue though. A lot of people do restrictive interventions. They don't work that well though. What I do is though, I talk to them. What did you learn? Why do you want to watch it? I also tell them, when you're watching it, why don't you talk to people when you're I make use of internet to help them to get better instead of discouraging them. Right. And in addition to, sometimes you have to put limits though.
Thank you, sir. And
There's
as far as
there's another question, sir.
Yeah, Judge.
There's another question from Dr. Zainab. What is the most common reason for eating disorder in Indian female?
Years ago, I don't know what I think, if I have to say, it's same as, of course, in US, the most common reason is idealization of the thinness by media and movies, models. That's a major reason. And also, they have, many of them at this point, what they're saying is they have a underlying anxiety, maybe autistic spectrum disorder, maybe depression. There is something more than just eating disorder. And of course, the last one is cognitive. They develop cognitive schema eventually. The being thin is the best eventually. So you make interventions depending upon where they are. You start with the schema and belief systems and move down to anxiety, move down to self-esteem issues. And of course, I don't know in India, is thinness is considered a character for marriage, idealization of the bride. I don't. That was the case though years ago. Somehow before the marriage you have to be thin. Your chances of getting a groom will increase. I don't know that was true. That was a thinking pattern. That was at that point.
I think it's still continuing, sir.
Does anybody can answer this question? I don't know what's in India now though. Does
It's still continuing, sir.
Yeah, can I answer that one, sir? Yeah.
Sure.
there are very few cases, mostly from Bombay. It's once again the Bollywood influence. For example, the top heroines are all very slim, tall and slim.
Okay.
So that is one. And in UK also, where I practice a few months every year, there I see the areas like Kent, which are close to London, have a lot of eating disorder population. But the much rural Wales, they don't have eating disorder cases as many. So clearly, the kind of cultural, the social influence is very important in this. And probably in Hyderabad, I've seen two girls. Both they lived in Saudi Arabia and came back. So they had some kind of the westernly influence. But Hyderabad itself, I think we have probably have very few cases. I don't know anyone has a clear anorexia patient in Hyderabad.
Okay.
So there's another question, sir.
Okay.
And I think the person's name is not visible, sir. Thanks for the wonderful presentation, sir. Please suggest some more practical tips to help parents to build rapport with adolescents, as like you suggested, having meal together, walk together, etc.
One, I think I'll send maybe some sort of paper or a PDF to you guys so that you can distribute. But mainly what I said though, that is parents, one, they have this belief systems, what's right, what's wrong. You want to know why they're doing what they're doing, what their belief systems are. And the second is, they think they're helping the child in the process. And then, but don't say it's not okay. Empower them. Doctor, that's my brother. This is my brother that's on Prasadarao. So the third is actually Dr. Salvatore Manuccian. He's an Argentinian psychiatrist, family therapist. He promoted what he calls structural family therapy. What he said, which is still true, parents do the wrong things because they are trying to prove to themselves they're good enough parent, strong parent. And if you give them some positive feedback, empower the parents, they can be good. They're not bad. They're good. Then they stop this wrong kind of disciplinary things. The second is, if this child is acting out their own psychology, psychopathology, or due to social pressures, you need to help parents to understand these too. Social aspects of their behaviors and psychological aspects of the teenage behaviors. That's what I keep using medicalizing though, because we're doctors. We have to use our medical knowledge, not just social knowledge, as much as possible. Otherwise, we become politicians and social advocates, which is okay.
Thank you, sir. So there's one question from Dr. Prasanna Kumar. What is your note in adolescent onset ADHD?
You know, I have to make a confession here. I'm a big ADHD person. I do, according to some people, I overdiagnose ADHD. But I don't. Let me tell you my thought about ADHD actually. This is my own. It's not just mine. There are a few other people believe that. See, if you look at the evolution of human race, pre-humans are around there for about 2 million years. The human precursors are about there for about 1 million years. And human civilization started about 30,000 years ago. And human civilization became industrialized about 200 years ago. And an average man became literary in 1890, that's when the printing press was invented. and the literacy rate went up more than 30% only in the last 20 years. What I'm saying is the demand on the brain is exponentially grown in the last 30 years because the brain is catching up to the evolution, social needs. It's not able to catch up. We call that ADHD. Like lactose intolerance, why not everybody has it? Same way, even though we are not trained to digest milk after age 4, only a few people have lactose intolerance, not everybody. Why? Somehow it's something genetic predisposition. Same thing about genetically predisposed people have a higher incidence of ADHD, even though brain is not trained to have this kind of demands on the brain to executive functioning. Because of it depends upon the brain, the demands on the brain. It could be as a 2-year-old, 7-year-old, 14-year-old, after residency, before residency, when you become a CEO. At each stage, the demands on the executive functioning on the brain increases. If you run into problems, do they have ADHD or adult onset something else? I don't know. I think it's ADHD. But the adolescents have a high reward-seeking behaviors. We have to keep careful. Is it ADHD or is it a reward-seeking behavior? We need to differentiate between the two. So you can ask questions about executive functioning and reward-seeking behaviors. That will give you an idea how much it is just reward-seeking, how much is ADHD. Adolescent onset. Onset, no. It's affecting them as adolescents because of the demands on the brain. That's how I differentiate.
Yes. So there are a few more questions, sir. From Dr. A. Rajesh, which disorder is common in US during adolescent period?
I'm sorry, say it again.
Which disorder is common in US during adolescent period?
Judge, Dr. Judge, we'll take up the last question. This could be the last question, I think.
I think not just number one is anxiety disorders, though. 2 is depression. Anxiety disorders are about 10%, all kinds of anxiety disorders, and depression is about 5%. According to some studies, ADHD is about that much, 5 to 6%. Yeah.
Yes, sir. This is one interesting question, sir. I think with this we will, sir, what is the reason? This is from Dr. K. Dayanand Rao. What is the reason that all young mothers feel that their child is not eating?
Are they Indian or American? No. By the way. You're asking an excellent culturally based questions. In America, though, all the white people think they're fat. They want to lose weight. Many of the African Americans, they want to become strong, not big. So they want to gain weight so that they can be strong. And all Indian mothers wants to feed, right? It's their need to feed the children makes them think child is not eating.
Yes. Thank you, sir. I think Dr. Paresha, sir, there are some more questions you have asked, sir. Due to paucity of time, we will stop here, sir. Sir, thank you, sir. I think your smile and the way you are presenting, sir, I think it's become more interesting, sir. And it shows how good your approach towards a child and an adolescent shows. Sir. Thank you, sir. Over to Dr. Maheshwaran, sir.
By the way, one thing I want to say about that, though.
Yeah.
I enjoyed tremendously being a psychiatrist and working with teenagers. I think you all do. That's why all of you are good people, are great psychiatrists because you choose to be one and enjoy it. Wish you all.
As our hair grays up, sir, I think we start to enjoy it more, sir.
Yeah. I think as already told, the adolescence is more interesting, at the same time more potential, at the same most vulnerable population. And as already talked about various issues regarding sexual orientation, sexual love perspective, and all those things, and even regarding substance abuse and exploration, risk-taking behavior. So I think you have covered all the topic, all the aspects of adolescence, and it was a very comprehensive presentation. I thank you, sir, for your wonderful presentation. And I think we have already crossed the maximum amount of time, and it's as already being a Telugu person, for you come aboard from US, and we also feel, I am also feeling coming home from Tirupati to Hyderabad. So it's a win-win situation for both of us. I thank you for your wonderful presentation, and I thank the organizers for giving this opportunity, and over to the organizers.
Dr. Fanikan to take over for vote of thanks.
Yes, sir. Thank you, sir. Today, it is my pleasure to deliver vote of thanks for the webinar, which is organized collaboratively by HPS as well as IAPP. I would like to thank today's esteemed speaker, Dr. Ramarao Gogineni, for enlightening insights. It was a wonderful talk and comprehensive talk, sir. It was a delight to listen to you. Thank you, sir, for your expressive discourse. I would like to thank today's chairperson, Dr. Nageshwar Rao and Dr. George Reddy for their expertise in chairing the session. I would like to thank the office bearers of IAPP and HPS, especially Dr. George Reddy, Dr. Dinesh, Dr. Minaj, Dr. Pavan, Dr. Praveen, Dr. Vashishta, Dr. Raghuveer, and Dr. Ajay Krishna for extending their support. I thank all the audience for attending irrespective of their personal commitments, and today being a weekend. Your participation is great in greater number, encourages us to carry out such programs with enthusiasm. I'm happy to share that today's attendees are more than 100 in number. Thank you for your active participation. I thank Hunch Pharma and their technical team for organizing this webinar. Once again, I thank everyone for making this. Good night and have a wonderful weekend. Thank you all.
Thank you. Thank you, sir. Dr. Ramarao, sir. Thank you, sir.
Thank you, sir.
Thank you.